There is a test that we do, that is helium dilution test. We use 10% helium to do it. Is it 10%? Wait a minute. No, I think it's 10%, yeah. 10% helium. So that's how come we're going to have a helium analyzer. Okay? Because what happens is that you blow into this parameter, okay? You breathe in and out of this parameter until the helium inside the equipment and what you're exhaling from your lungs will equilibrate. Okay, so that's how we measure the concentration of helium. Okay? And it says that do not use with flammable gases. It is used in the helium dilution test. Oh no, wait a minute. So if you want to calibrate a helium analyzer, we don't have any helium in room air. We have traces of helium, not a lot. So if you let the sensor to room air, it's going to read 0 because we don't have helium in room air. And then if you want to calibrate it to 10%, which is the concentration that we use for that test, all you have to do is to expose the sensor to 10% helium concentration. And then we'll calibrate it to 10%. Okay? Oh, sorry. And then we have carbon dioxide, carbon monoxide analyzer. Again, there is a test that we do that we need to use traces of carbon monoxide concentration, like the diffusion test. Now, diffusion test is testing to see how well things can diffuse from your lungs into your blood. Because now we have the alveolar capillary membrane, like that. This layer here. So now when you breathe in air, so the oxygen in the air has to cross into the blood, but before then it has to go through the alveolar capillary membrane. Okay? If the oxygen cannot go in, then we have a problem here. We have diffusion defect. A lot of things can cause diffusion defect. So that's what we're doing with that test. We're testing diffusion capacity. Because carbon monoxide diffuses about 240 times more than oxygen, we like to use the carbon monoxide. So it's like if carbon monoxide cannot diffuse into your blood, then you got a major problem. That's what that means. If you cannot diffuse across, we have a major problem. Okay, so that's what we do with the diffusion defect. So that's where you're going to need carbon monoxide analyzer. And then carbon monoxide, we really don't have a lot in air, just traces. So if you expose it to room air, it's going to read 0. Okay? You read 0. And then I think what we use for that test is, if I'm not mistaken, I think it's 0.3% carbon monoxide, just a little bit. Because carbon monoxide is dangerous. Remember, it will diffuse very quickly and attach to the hemoglobin so that you cannot get oxygen. Okay, so that's why we use just a little bit of it so that it doesn't affect your breathing a lot. So it's either it's 0.03% or 0.3. I have to look that up. Okay? And then we have nitrogen analyzer as well. There is a test that we do called the nitrogen washout test. Nitrogen washout test is one of the ways that you can measure the functional residual capacity. And then in this test here, what they do is they have you breathe in 100% oxygen so that you can deplete the nitrogen inside your lungs. Remember now, when we breathe in, we actually breathe in more nitrogen. But the thing though is that the nitrogen that we breathe in doesn't cross over the alveolar capillary membrane into the blood. It stays in the lungs to try to keep the lungs open. The volume of nitrogen keeps the lungs open. So the nitrogen maintains the functional residual capacity. Okay, so if we are measuring the FRC, then we want to breathe in oxygen to deplete the nitrogen inside the lungs. So we have the analyzer there to measure the concentration of nitrogen as the patient is exhaling out. Okay? So if we want to, if we calibrate nitrogen on room air, it's going to read 78.9%, or approximately 79% on room air. Okay? If you want to calibrate it to 100%, then you're going to expose the sensor to 100% nitrogen, meaning a nitrogen that doesn't contain anything else but nitrogen. If you want to calibrate it to 0, then you're going to have to flush the sensor with any gas that doesn't have nitrogen in it. But that's the only way it's going to read to 0 on room air. Any questions about that? So review time. How will you calibrate an oxygen analyzer to 100%? Basically, what you have to do is to expose the sensor to 100% oxygen. Okay? Let's put it inside the bag, and then you fill the bag up to the flow meter, turn the oxygen, 100% oxygen on, it will sense it, and then it will go up to 100%. Okay? A nitrogen analyzer calibrated to room air will read what percentage? It's going to read approximately 79%, because that's the amount of nitrogen that we have in room air. What is the acceptable standard deviation when using a super syringe to calibrate a spirometer? That's 3.5%. So 3.5% of 3 is 0.105. So if we're calibrating the spirometer, we get a number that is over 3.105, then that would mean that the spirometer is out of calibration, and we cannot use it to do any type of test. And then if we're calibrating the spirometer, we get any number that is less than 2.985, we can't use it as well. You know? So we have to have that 3.5% between 2.985 and 3.105. Okay? How will you calibrate a nitrogen analyzer to 0? Well, we're going to have to flush that analyzer with a gas that doesn't have nitrogen in it. That's the way you're going to calibrate it to 0. An oxygen analyzer calibrated to room air will read what percentage? It's going to read 21%. If you let the sensor out to room air, it's going to read 21%, because we have 21% oxygen in the room air. Now, the barometer is used to calibrate the body bags. Any pressure equipment will be calibrated with a barometer. So that's what a barometer looks like. It's got a mercury column, okay? The mercury column exposes it to the pressure, and the pressure here moves the mercury column up, okay? Until it equilibrates. Okay, so now, the only time that you may need that is if you are doing the body box, because you want to calibrate the pressure inside the box. Okay? Now, aneroid pressure manometer. This is the pressure device or pressure gauge that we have in things like blood pressure cuff. Okay? Like right there. Okay? That will be the aneroid manometer. It displays pressure. It has like a spring loaded device inside it. And the more pressure that it senses the more the spring is moved, and then the lower thing moves up. Okay? It doesn't work with electricity. It doesn't work with battery. It's just the spring. The more tension you apply to the spring, the more it's going to move that level needle up. Okay? And then, because sometimes when they come to the BFT lab, we want to check their blood pressure as well. And then we have this one here. You probably saw this one here when you were doing your body parameters, if you did that. Okay, this is also a pressure manometer that we use to measure MIP, what we call the MIP, maximum inspiratory pressure. Okay, maximum inspiratory pressure. Now, the maximum inspiratory pressure measures the strength of the respiratory muscle. Okay, your ability to cough and clear your airways of secretions, pulmonary secretions. That's what we're testing. So before you intubate your patient, remember that once you intubate your patient, they will never have effective cough. They don't have productive cough once you intubate them. Okay? In fact, you depress a patient's ability to cough once you put down that ET tube. Okay? So that's what we're testing now. If we intubate you, are you going to be able to cough effectively if it's needed to clear your airways of secretions? Okay? So what we do then is, the MIP is like negative 80 to negative 100. But now some books may say negative 60 to negative 100. Okay? Is the amount of negative pressure that you can take, okay, when you try to breathe in. You know, we actually create negative pressure when we breathe in, spontaneously, because your diaphragm will drop and elongate, okay, so that causes you to create negative pressure inside your thorax. Now, the pressure inside your thorax now is negative, lower than the pressure on the outside. So that's what causes the air to begin to come inside your lungs, because gases move from area of high concentration to area of low concentration of pressure. Okay? And then for extubation purposes, well, we take negative 20 or less. If it's negative 30, the patient is stronger. If it's negative 60, the patient is stronger. Okay, so the more negative number that you get, the stronger the patient's respiratory muscles. Okay? The reason that we go all the way down to negative 20, okay, which is of course less than negative 80 and negative 100, is that if you have your patient intubated, they're not actually using their respiratory muscles. Okay? The diaphragm does not contract actively when you intubate your patient, especially when they are on a full mechanical support mode. So patients can develop muscle atrophy. They have not been using their muscle. They're not using their diaphragm. So there is no way that you're going to get negative 80 to negative 100 on somebody who has been intubated for a while. So that's why we're saying, well, negative 20 is the cutoff. That's a critical point. If you can get negative 20 or less, there's no need to intubate you. Okay? I mean, to extubate you. Any questions about that? And then we have the same thing we can use, the same manometer we can use for MIP. Okay, this one here stands for maximum expiratory pressure. Maximum expiratory pressure. This one here tests the patency of your airway. If your airway is patent, we tell the patient to breathe in, and then they will blow into the device. Okay? And then once they blow into the device, the needle moves. Okay? We want to see how much pressure that you can create when you blast that air out. Okay, so the amount of what is normal is 60 to 100 centimeters of water. the minimum acceptable is 40. If you get less than 40, then it means that your airway is not patent. Something is obstructing your airway, okay, you can't breathe very well. Okay? Any questions about PFT equipment? Okay, I think that's it for today.